So much, Brian. I really appreciate it. Is this a good volume?
Sounds great.
Okay, great. Okay. Well, I am just delighted to be doing this webinar today. I have really enjoyed working with the Navigate teams in Washington State. It's the New Journeys is a really excellent program, and I'm so glad that the Navigate team is involved, and it's been a wonderful experience for us. And now to expand it to the next stage is always a great feeling when things move that next step. So thank you all for being on the call. I am Susan Gingerich, and I'm here in Philadelphia, actually. And I have been working on the Navigate program since the very beginning when it was RAISE, Recovery After Initial Schizophrenia episode in 2009. So for the past 8 years, I've had the privilege of being involved in this first episode program. Before that, I was also working in social skills training and also in illness management and recovery, which is something we did quite a bit with Maria and her PAC groups in Washington State. So it's just a pleasure. And I also had the good fortune to live in Seattle for a year, and I worked at Harborview in the emergency room. And that, if nothing else, that was a very good education. You learn so much in the ER there. So as we begin today, I just thought I'd put the agenda in front of us, is that we'll just start off when we're talking about psychosis, what do we mean? And then next to talk about recognizing signs that psychosis may be developing. And it may look different than it does when someone's had the illness for a while. Then we'll move to what is the treatment that we recommend for early psychosis related to schizophrenia. And from that, particularly to talk about Navigate and how it fulfills the coordinated specialty care criteria for working with clients in their early experience of schizophrenia. We'll also talk about what's happening so far with the Navigate teams that are already in place. And we'll think about what it would be like to work as an actual team when you begin seeing clients. What does the team look like? What kind of meetings do you have as a Navigate team? Being able to track clients' progress. And then we'll be thinking about supervision and consultation. And as you're probably already very familiar with, the collaborative person-centered treatment planning approach, which is what we also use in Navigate. So I'm excited to begin. About halfway through, there's a video I'd like to show, just to bring in the client voice. It's a video of some young people who've experienced psychosis, and they're talking about the experiences from their point of view. So about halfway through, we'll do that. Okay, so first a few facts is that it's approximately 100,000 young people experience an episode of psychosis each year, which is about 274 young people each day. And the average duration, however, of time between they first experience psychosis and when they get treatment is about 2 years in the US. That for 2 years, people are very troubled and having problems and concerns, but they don't get help with it. And we're in the mental health system, we have been waiting for people to come to us. And these young people don't come to us until things get really bad. So we're very eager to not only provide good treatment, but to provide it earlier in their experience. And then that it has a lot of effect on these young people. And I think that would be clear to everyone on the call who's used to working with people with schizophrenia. But it's an interesting fact that 3 times as many young people who've experienced psychosis will drop out of school compared to their peers. And that's just one statistic. And we know what happens when people drop out of school, what happens to their potential employment and their potential future in their life. So that already the illness, even if they haven't come to inpatient hospital, they haven't been arrested, any of those things, they're still having very important things happen to them that we'd like to help them avoid, such as dropping out of school. Another thing is that people have this stereotype of psychosis and schizophrenia, that they're violent towards others. And we won't deny that there are some incidents that occur where someone who's experiencing psychosis, and almost always who is untreated, not receiving any treatment for their illness, are involved in some violent acts. However, the vast majority of people who experience schizophrenia are more likely to be the subject of violence rather than the perpetrator of violence. And they're also more likely to have acts of violence against themselves. So at least 10% of people with schizophrenia will die by suicide, which is 10 times as high as it is for the general population. And then finally, that the World Health Organization, WHO, ranks psychosis as the third most disabling condition in the world. That's in addition to paralysis and physical disabilities as well, is that it's recognized highly as something that really needs attention because it has such an effect on people and their abilities in life. So that's kind of as we talk about these statistics and this information is kind of building up to why the U.S. started to make this approach wanted to make a full-scale approach to early intervention. Another reason is the relative prevalence of schizophrenia, that it's highly, it's much more common than people think. And you'll see by this chart, which is just a graphic of how many people have schizophrenia compared to how many have Alzheimer's. It's twice as many as have Alzheimer's. It's 5 times as many people as have MS. 6 times as many who have diabetes. And the reason we bring that up is that almost everybody knows what diabetes is, right? In this community. And if someone starts to show signs of it, or there's diabetes in the family, that they're kind of open about it and they'll get help with that. However, it's only 1/6 as common as schizophrenia. And with schizophrenia, people don't know what it is. They don't know what the signs of it are. And they're much more likely to hold back on getting help and treatment because of that confusion about it. And you also think about things like Alzheimer's, which we read about a lot in the news today, in newspapers and magazines, see it on television and documentaries, is that there's a lot of attention to that, which is great. We should know and understand more about that. And almost anyone you talk to knows what Alzheimer's is nowadays. And they also know that no one's to blame for it. And we would like the same for schizophrenia, that people know what it is, they have information and facts about it, not these myths that have accumulated, and also that they know it's not the person's fault. So just kind of trying to put that in perspective as one of our goals with this first episode program is to make it more understandable to the general public, and that they would just get treatment for it instead of hide it. Okay, but then on the good news side is that treatment works. And especially for these young people, it's so important to know that medication can really address the symptoms very effectively. If people take the medication as prescribed, that 77% of those experiencing first episode psychosis will have a remission of symptoms. And that's not just that they'll get better, it's they'll not be there. So the idea that someone could not have voices, that someone could not have delusions, is definitely a possibility with young people when it's their first episode. So we want to keep that in our mind all the time, that things are not the same for this younger population as they are for people who've been ill for a long time. We're looking for a whole different future for them. Okay, so we feel like this is a message of hope right now, that it's almost like a new era in the treatment of schizophrenia, and that is that by providing early treatment in a coordinated fashion, so that people are getting comprehensive care and that it's addressing all aspects of the illness, that we're helping to build the best foundation for these individuals, that they have a high potential to experience recovery and to live full, rewarding lives. And that's certainly not the message I got when I went to graduate school. So we want that to be the message that we give and that people start to take in. Okay, so we're talking a lot about first episode of psychosis. And just want to take a minute to talk about what we mean when we speak of psychosis in this context, is that it's more of a symptom rather than an illness. And that it refers to a condition of the mind as involving loss of contact with reality. And that would include hallucinations, delusions, and odd speech, and it might be difficulties with social interaction and carrying out daily life activities. Someone described psychosis in a very expressive way, I think, one time by saying it's like dreaming while you're awake. It feels very real. And psychosis as a symptom, not schizophrenia, but psychosis as a symptom, occurs in 3 out of 100 people at some point in their lifetime. So a lot of us, if we think about it, may have had an experience of psychosis ourselves, that it's more common than people think. And it can be caused by a variety of things. And I just want to review that because you're going to be in a program where we're just talking about one type of psychosis. Oops, I'm sorry. But we want to just keep in mind that it can be caused by many things. And that's especially relevant if you're going to be evaluating people for the New Journeys program, is to kind of be able to tease out what, the presence of the psychosis, first of all, and then to think about if the psychosis is present, what is it being caused by? And I'm just going to ask one question now, just a technical question. Are the photographs on the left of my screen cutting off the words of the slide?
What? Can you repeat your question?
There's photographs on the left. There's videos on the left side of my screen of everyone's faces.
We can't see that. All we can see is your presentation.
Oh, that's great. Then it's not blocking off the words.
Yeah. No worries.
Thank you, Brian.
Yeah.
So it can be caused by many things, and many of you are very familiar with this. But let's just kind of put it out there so we can all be talking about the same thing. Of course, psychosis can be caused by drugs. Things like LSD are famous for it. Visual hallucinations, auditory hallucinations can be caused by drugs. Also, they can be caused by alcohol. People can have psychosis while under the influence of alcohol. Psychosis can also be the result of extreme stress. And it can be the result of environmental deprivation. So like if someone is in solitary confinement for a long period of time, they don't have any access to stimulation, it can cause psychosis. It can be caused by sleep deprivation. If people are kept from sleeping for a long period of time, they start to hallucinate. It can be caused by damage to the brain. And it can also be caused by mental illnesses. And so that's the type of psychosis that this program, that Navigate and in turn New Journeys, is really designed to treat. Sorry, I have to find now the, oopsie. Oops. So I'm just
in case if it's too distracting, those little videos, you can move them around on your screen to a place.
Oh, thanks. Now I'm just trying to find my little cursor here. It's disappeared on me.
If you have multiple screens, okay, there you go.
Okay, there we go. So the treatment of psychosis depends on the cause. So that if it's drug and alcohol caused, then you want to think about substance use treatment. If it's caused by excessive stress, you want to work on stress management and reducing the stress. If it's environmental deprivation, you want to be able to gradually reintroduce the person to a rich and stimulating environment. Sleep deprivation is involved in returning the person to a safe place where they can get their sleep again. And brain damage benefits from specialized neurological-based treatment. And the reason that we're saying this again is that with time and treatment and the elimination of the causal factor, if possible, that many episodes of psychosis end and don't return. But we want to recognize that and be able to kind of be on the alert for what is it that's at the basis of this psychosis, and trying to rule out things that we are not really designed for treating. So we're designed to work with schizophrenia, which is the most common mental illness with psychosis. And 1 out of 100 people, for example, have a risk of developing schizophrenia at some point in their life. The way I think about it is that I was in a graduating class of, I think we had 700 in my graduating class. And that would, by the statistics, that would mean that 7 people probably developed schizophrenia from my class. And I know 2 or 3 of them already. And it's very likely that the other folks, I just didn't know them or didn't follow up with them. So it kind of brings it down to a more personal level if you think about those kind of numbers. Or if you belong to a church with 200 people, probably there's 2 folks in the congregation that either have schizophrenia or have a loved one, more likely to have a loved one. It's most likely to appear in late teens or early 20s, which is why Navigate and New Journeys is designed for that population age. And it needs a coordinated and comprehensive approach to treatment. That the more different pieces of it that you can bring together, the more thorough the potential for recovery is. I apologize, for some reason this cursor is giving me trouble. I think I'm just going to click it every time. And when we think about symptoms of schizophrenia, there's certainly a psychosis, and that would be the delusions, hallucinations, disorganized speech, and disorganized or catatonic behavior. But there's also other symptoms associated with schizophrenia, such as the negative symptoms, the lack of interest in things, the lack of energy or drive, the lack of initiative, or sense that something would be worthwhile or worth doing. We refer to those as the negative symptoms. And there's also cognitive difficulties, problems with focusing and attention, and difficulties with memory. And those are some things we didn't know. We've known about negative symptoms for quite a while, but we haven't been as aware of cognitive difficulties until more recently. So I think it's good for us to come into the New Journeys realizing that people may already be having some cognitive difficulties, which of course would influence school and work. And just a note is that the items on the screen on this slide that are in blue tend to respond the best to medication. And the items in green, the negative symptoms and cognitive difficulties, are things that tend to be more resistant to medication and are more responsive to psychosocial interventions. And we're going to get into that a little bit more. Just to back up a little bit about the diagnosis of schizophrenia, with DSM-5, we're looking for 2 of what they call the criterion A symptoms for at least a month that are on the screen: delusions, hallucinations, disorganized speech, negative symptoms, and also to have a decline in functioning. And just want to mention that the catatonic piece, I thought somehow I hadn't seen people with catatonia in a very long time in my practice. And I thought it was maybe just people that maybe have been ill for a very long time. And it turns out that's not the case. The catatonia does occur for our young people, and it can be very distressing. People feeling stuck, like they can't move, they're in the same position, and almost like frozen. Which all this is about is how important it is to screen carefully and to evaluate folks. And in Washington, for New Journeys, people are learning how to do very careful diagnosis through the SCID, which is the Structured Clinical Interview for Diagnosis, SCID. But we just want to make sure with the diagnosis and the screening, it's not like we're trying to refuse people the program. It's more that we want to make sure that the person gets the right treatment for his or her symptoms. We wouldn't be doing anybody a service if their psychosis, for example, is more due to borderline personality disorder, where they have brief intermittent psychosis. We'd not be doing them a favor if we weren't giving them DBT or dialectical behavior therapy, because that's really designed for borderline personality. Or if someone has psychosis related to severe depression, we'd want to make sure that we were treating the depression and not treating it like schizophrenia. So we're just trying to always think in mind about where we're trying to make the right match. What does the person have, and what is it that we have to offer? So we talked about what are the sort of the textbook symptoms of schizophrenia, what's in the DSM-5. But I think it's also important to know that the people who come to us may seem a bit, that their signs, the way that people know they're having psychosis, may seem a bit different. And one thing we look for is a marker is when the person's performance in school or work or family life is rapidly dropping. So sometimes it's people's functioning that we notice first, rather than the fact that they're hearing voices. The voices may be causing this performance decline, but they may not be as obvious as the actual decline. So, for example, if a student who's usually getting A's and likes to go to school, enjoys learning, suddenly doesn't want to go to school and can't explain why. Their grades start dropping. They start leaving class early. And there's not drugs involved. It seems to be something about their ability to stay in school and stay focused and feel safe in school. So the performance in work and school may be dropping, or somebody who used to enjoy doing things with their family may suddenly pull back and only want to spend time in their room. The person might be saying or doing things that are out of character. And it might be something like what I heard about recently is the person started putting dark curtains on the roof, on his windows, because and he couldn't explain exactly why, but said if we would understand if we knew all the facts. So he was doing things that were a little odd, and he couldn't explain them, and it had to do with psychosis. Oftentimes, emerging psychosis looks like depression. I must say that a lot of the clients that we see have previously been diagnosed with depression. That's a more common diagnosis that people are familiar with. They're more common, and it's more commonly understood as happening with young people. And it looks like depression. The person seems down. The person doesn't like to be social. The person might not have interest in things. So when working in a children's agency, being very careful that if a young person looks like it's depression, to ask a little bit more. We had one person who said, yeah, I'm just depressed. Oh, what are you depressed about? Well, I'm depressed because the aliens are actually taking over my school, and the teachers are not real teachers. Oh, okay. So that's like they may say it's depression or may sound like it's depression, but you always want to ask those follow-up questions, asking people to tell them more. It may look like irritability, and people might start being very sensitive to criticism, being snappish, and not be able to tolerate much in terms of even friendly joking around. And then finally, it might be problems sleeping that might bring people to our attention. And again, that follow-up question, I know Dr. Robinson talks about, who's our prescriber trainer, talks about a young person who said, it's okay, I'm just having trouble sleeping. Oh, well, what happens when you go to sleep? Well, the voices get louder. Okay, So it's the sleep could be from all different kinds of things. And one of them might be because they're having trouble with psychosis. In addition, here's, as if that's not enough, here's some other things that also might turn up. One thing we didn't mention was suspiciousness. And it's a little different than outright paranoia, but being suspicious of other people's intentions, being suspicious that others don't like them or are against them is important to pick up on. Decline in personal hygiene. And as we know from people who've been ill for a longer period of time, they might stop taking showers even though they used to all the time, or they might not take care of brushing their teeth when they used to before. And then you can see on here that there's lots of other situations here that might come to the attention of parents. And that's why one of the things we think about is that it's a tough age for parents to know what's a symptom of something serious and what is just being a teenager. Is that some of this stuff can happen when a person's just a teenager. I'm going to go back to one here, is like, but not go back, I seem to not be able to do that. But it's just like, it's a very hard to know what's caused by what. And also, I want to just delineate, when I said that we want to make sure that we understand what the cause of the psychosis is and be able to get them to the right treatment, I mentioned substance abuse as being the cause. I just want to mention that you can certainly have both. You can have schizophrenia and substance use. And we would definitely take those folks into New Journeys. That's not a rule out. However, one of the things that we found is we have to be on the alert that young people are more likely to be using drugs. In the RAISE research, I think it was over 50% had a substance use problem. So we've come to almost expect it rather than to be surprised at it. And it doesn't, there's not strong evidence to say that drug use causes schizophrenia, but there's a lot of research to show that it makes it worse. So kind of just keeping that in mind. So we've talked about what folks might look like if they are experiencing this early psychosis. But we also want to, where would we find them? They're often first identified, unfortunately, in inpatient facilities because things have gotten extreme. So for all New Journeys teams, you're going to want to have a very good relationship with the inpatient hospitals and inpatient units or wards in your area, because they will often be the place where young people are identified as having psychosis and having it for the first time and it being related to schizophrenia. Emergency rooms, another place that sometimes things start there's a really bad experience and families will bring their loved one into the ER. I remember several incidents of that at Harborview, in fact. Crisis services, sometimes people will end up calling for crisis help. And then we get down to the things that are a little less usual. One is the jail system, is that sometimes people will end up with behaviors that get them in trouble with the law, and they end up in jail. And we want to, I know there's one of our teams that has a very good relationship with the jail system in their city, and they've gotten a lot of good, accurate first episode clients whose behavior was out of line, and they ended up in jail, but they should have actually been in mental health treatment. Another place that we often will see people first recognize would be with pediatricians and regular doctors, is that a lot of time parents don't know what a psychiatrist is. They don't know what a psychologist is, but they do know that their family doctor is someone that they turn to. So that they go and they'll talk to the family doctors or the pediatrician, because a lot of our clients are still seeing a pediatrician. And so that's where it might first come to light. Schools, like middle schools, high schools, colleges, universities, trade schools, vocational programs. All those things are places where someone might recognize and see that there's something going on. Also, children's services, foster care, those are places that are also excellent to keep in mind. I'm going to move down this one and go to religious leaders. Is that some parents are quite suspicious of the mental health system, and they turn to their pastor for everything. And it might be that it's their pastor or their rabbi or their imam that is the person that they turn to. So it's really great if there's someone in your town, some organization in your city or town, where the religious leaders come together, like a minister's council or a spiritual council, and you have a chance to do a short presentation. I did that one time, and several pastors came up to me to talk about people in their congregation. Not all of them were schizophrenia, but there were some that sounded like they needed an evaluation. Sometimes you can go to substance abuse programs for young people, and what they're finding in the substance use program is the person's sober, but they're still acting in an unusual way. But I guess when we think about identification, always keep in mind that it's the family that's the first line. And so anything we can do to help family members be more likely to come to us for help if they see something about their young person. And one new thing that's happening in a lot of places in the country is mental health first aid, where it's for the layperson to learn more about first aid. What would you do if someone were choking? You give them the Heimlich maneuver. If someone has a mental health problem, people don't know what to do. So this is the idea, is that people can learn more about mental health and how to respond. And that's a good place, if there's a program in your city or town, to do a presentation and tell them what you're doing. Okay, so now let's kind of narrow into this. We've talked about what is the psychosis, and what is it like in young people, and where do you find it? Where do you find people that are experiencing this at a young age? We're going to move now to what the programming is like. And the Navigate program is a program for early treatment. And it was designed starting in 2009, which is when National Institute of Mental Health launched what they called the RAISE initiative. And RAISE stands for Recovery After an Initial Schizophrenia Episode. And they awarded contracts to 2 teams in the country to develop early treatment programs for persons with first episode psychosis. We're late to the party, by the way. The Europeans and the Australians have been doing this for much longer than us. But the US finally said, we've really got to do something here. And that's when this RAISE initiative began. And the two contracts were to the RAISE Connection program, which is out of Colombia, and it's now called On Track USA. And then there was the Early Treatment program, which is now Navigate, which is the program you're going to be working with. And both have websites. I have the website up here for Navigate, and I'll put it up later again. But you can also look up On Track USA, and their materials are available as well. Both programs were done under the auspices of National Institute of Mental Health. They're in the public domain. So the research we did during RAISE was we wanted to do a randomized control trial. How are we going to really prove that what we're doing is making a difference? We think that having a comprehensive care approach and having it be a team-based approach should be helpful based on what the other research says, but we had to really check that out. And we had 34 sites. Half of them got what we call community care. It was whatever agencies already provided for first episode clients. And treatment, sometimes called treatment as usual. And the other 17 got Navigate. And we were looking at a lot of data, outcome data, and we wanted to make sure that we were paying attention, not just did the person go to the hospital less often, or their symptoms were better. Those things are extremely important because it's hard to move forward in life if you're having symptoms. It's hard to move forward in life if you're always going back to the hospital. Those are important. But we also wanted to look at, can we actually get people back to work? Can we get them in school or to stay in school? And can we improve their quality of life? So those were things we were also looking at. And then we had a training program for all the Navigate clinicians and consultation calls to follow up with them. And the team collected a wide range of outcomes so they could compare the two treatments. And here's a map of where all the sites were. And we tried to get things across the US. And we did succeed in East Coast, West Coast, Midwest, and South. We're pretty pleased about that because we didn't want it to be something that could only succeed in Pennsylvania or only succeed in the Northwest. And as you see, that Washington State was one of the sites, and that was Peace Health. Wait a minute. I can't be positive if that was, what was do you know the Washington site, Maria?
Frontier Behavioral Health.
Frontier, okay. The reason I don't know that, I have to defend myself, is that they were a control site. And we were not allowed, we didn't have any communication with them as part of, because we were trying to let them do exactly what they already were doing. We were trying not to interfere with that. Thank you, Maria. It was Peace Health is in Oregon, and they were a Navigate site. So then we looked at the outcomes. And compared to clients getting customary care, Navigate clients were more likely to stay in treatment. They had greater reductions in symptoms. They had greater improvements in quality of life and greater rates of participation in work and school. So those are the results we were hoping for, and those are the results that we got. And folks who are interested in more about the details of that, the analyses that were run, et cetera, there's some research articles out there that we can put you in touch with. But these were the sort of like the big ticket items that came out of the research. We also learned in that the shorter the duration of untreated psychosis, what we call the DUP, the better the outcome. So the quicker people who came in had only been ill 6 months, their improvements were stronger than the ones who came in had been ill for a year. So those are just things to kind of keep in mind, is that as you work on treating the clients, also be working on trying to get them in sooner. It's because the sooner psychosis is identified and treated, the better it goes. And I know that probably sounds so obvious to folks, but we didn't know this for sure in the past. We didn't know that this would make a difference in the long-term outcome, and now we do. So since the research project, here's where Navigate is happening. You can see a range of different states, again, North and South and Midwest and the Northeast, and we're proud to see Washington there on the second column. And here's some more that we're also working with, including Israel actually was very interested in the Navigate program. And one of our trainers, Piper Meyer, went over to Israel and did some training there. And they now have 3 teams in Israel. There's some other trainings that are coming up that we'll hope to add to this, but places like the Virgin Islands, Wyoming, we're going up to Canada in a couple of weeks, and New Hampshire. So you're part of a large network of programs that are all doing Navigate. So then to narrow it down a little bit more, the New Journeys teams that are currently using the Navigate model in Washington State would be Comprehensive Healthcare in Yakima, Behavioral Health Resources in Thurston, Valley Cities in Renton, and the 2 New Journeys teams, Behavioral Health Resources in Grays Harbor and Community Services Northwest in Vancouver, which will be starting later in the year. And we're also real pleased that University of Washington is now developing a Navigate program at Harborview and at Seattle Children's Hospital. So this is great news, because what you really want is for no matter where a family lives, if their son or daughter develops schizophrenia, you want them to have a place that they can go and get specialized care, that it shouldn't be just folks who are in one particular city, one particular area. So let's talk a little bit then about the specifics of the Navigate program. And I'm just going to mention that, again, that this is our website, navigateconsultants.org. And you can find all the manuals, and you can find research articles listed, and you'll find videos of the IRT, the Individual Resiliency Training. So we're designed to help people with schizophrenia, schizoaffective, or schizophreniform. And we're based on the stress vulnerability model, which a lot of people may be familiar with. And we'll go into each of these in a little bit more detail in the later slides. We're emphasizing recovery and resiliency, not just, it's not just surviving schizophrenia, but it's thriving with schizophrenia. We help people learn illness self-management, and we use psych rehab kinds of principles in terms of skill building. And then everything we do, everything we put together was informed by this age group, by the special issues for a first episode psychosis client. I always try to put on the glasses of a person who is experiencing first episode rather than thinking about every single person with schizophrenia. We were thinking about this particular one. So let's take a minute and look at the stress vulnerability model, which is, it's also part of illness management and recovery. You've probably seen this before, but it was something that helped us as we were developing the model, is that we think of schizophrenia as being based on it's a biological vulnerability that people are born with, and that stress can trigger an episode or make it worse. If someone has a very high biological vulnerability, it may not take much stress to trigger an episode or a first episode, just ordinary things. If they have a low biological vulnerability, it might take a big event that triggers off the episodes. And the things, but the part of that I like about the stress vulnerability model is kind of conceptually, there's things you can do for the biology and things you can do for the stress. And for the biology part, medications help, staying away from alcohol and drugs. Both those things are very, very powerful in terms of treating the biological vulnerability. And then on the stress side would be having social support, like having family involved, having people that you can turn to, having coping skills. How do you cope with symptoms? How do you cope with stress? And having meaningful activities. All those things can actually help reduce stress. Someone said once to a client, says, it's too stressful for you to work. And he said, actually, it's too stressful for me not to work. He said, I am so bored and I get into so much trouble when I'm just on my own. I'd rather work. So having meaningful activities is something that's equally important as a in treatment. Okay. So in terms of using the principles of illness management, that's where we think about things like clients learning that symptoms and relapses can be reduced by using medication, by minimizing drug and alcohol use, by reducing stress, and then by increasing social support and increasing coping skills. So some of the things have to do with reduction, some of the things have to do with increasing. And then in terms of psych rehab, there may be some people in the audience here who have had psychiatric rehabilitation training. And you'll recognize in Navigate that we actually look for recovery outcomes and try to get there. What is it going to take to get these recovery outcomes? So that often involves teaching skills and providing environmental supports. It has to do with using supported employment and education. It has to do with teaching resiliency skills and involving family and social support. And as you are probably quite familiar, medication is extraordinarily helpful in the treatment of schizophrenia, but it's not, for most people, it's not enough alone. So all these other things need to be brought in. Okay, so I'm going to say taking into consideration the special issues for first episode psychosis clients. So we have those, the foundational and the principles of how we develop this, but we also had to think about their developmental stage, that they're just young people. They're often in that push-pull thing where they want to be independent adults, but at the same time they need stuff from their parents. They're just striking out on their own. And that they're also, it's quite traumatic to experience psychosis for the first time. So we want those things in mind as we not only develop the treatment materials, but also thinking about delivering them. And this seems like a good time to just take a little pause and ask for questions. And then we'll do the video about with the client voice in it. Anybody have any questions so far about what we talked about?
And just remember to unmute yourself before you ask your question.
Or comments. Maybe there's something that sounds really good to you, or something that you think, I'm not so sure about that thing.
I'm just curious. I don't know if ours is off mute.
Yeah, it's on mute.
I was just curious. I know the Navigate obviously focuses on the younger population and the first episode. Is there any research that's been done in terms of efficacy in working with someone who's had been symptomatic for a longer period of time?
I like that question because I have a real soft spot in my heart for people who've had the illness longer. And we don't have research yet to show that it's helpful to use the Navigate materials, but there's a lot of indications to me that it would be helpful. There's probably nothing that would be counterindicated about using Navigate materials with an older population. And I know from my own experience, there's in individual resiliency training. We'll get to that in a minute. There's a module on what's called processing the episode, where people have a chance to talk about the first time that the illness developed and what their reactions to it was, what happened. Was it embarrassing? What did they think was causing it? What do they now think is the cause of it? What do they now think about their hope for the future? And I did it with a person who'd been ill for about 15 years. And no one had ever asked him these things. And he found it very helpful. And then to talk about how far he'd come, et cetera. So I only have a tiny little experience with that, but it made me actually eager to think about what parts of Navigate might be especially relevant to persons with longer sepsis. There's quite a bit in IRT, in fact. There's a focus on strengths, and there's something called the strengths test. And I think any client would benefit from that. It's really nice. It focuses on what are you good at? What are some of your qualities and abilities that are actually strengths? We're not just going to focus on the things that are not going well for you. And in addition, we've known for a long time that working with families of people that have had the illness for a while is helpful. Behavior family therapy and multiple family groups for persons with psychiatric disorders, there's good research on that. And so that the family intervention is also something to be thinking about, might be helpful for clients who've had the illness longer.
And I would just add to that, Susan, if I may, that
yes.
Schizophrenia treatment guidelines for this country, as well as for most of the developed, in fact, all developed countries where we have schizophrenia treatment guidelines in place, do specify that care should be comprehensive and coordinated. So they don't stipulate that it's a coordinated specialty care model per se, but that it would include medications if the person's amenable, an evidence-based psychotherapeutic intervention, supported employment and or education, peer specialists. So
yeah, I think, and family. I think families.
and family, yeah.
So that's a very good way to put it in perspective. These are the kinds of things that are suggested in the guidelines for the U.S. Yes, absolutely. They just don't happen to become in a coordinated specialty care package. Those people who are working with folks with who've had the illness for longer or might have different illnesses like bipolar and depression, I do recommend illness management and recovery, which is also, it's an evidence-based practice that's on the SAMHSA website. And it's got a series of handouts and modules that are designed for people at any stage of the illness. So that's at the samhsa.gov, and you look up evidence-based practices and toolkit. There's a toolkit for IMR online.
Thanks.
Sure. Anything else that people might want to ask?
Susan, this is Maria. I just wanted to, if you wouldn't mind, I know that you're going to speak more to inclusion criteria or admission criteria at the training, and we'll kind of crosswalk that with the New Journey's admission criteria specifically, but just to kind of clarify, if you will, I know there was a lot of focus on sort of people who are younger, but just that we are seeing sort of some early psychosis in older folks too, and kind of speaking to sort of how old we can see that.
Right, right. Well, during the RAISE project, it was, the age range was 15 to 40, because we actually had some people who came in their 30s, and it truly was their first episode. Under 15 gets really hard to actually determine the diagnosis, and it's more rare under 15, and also it's likely to be even more likely to be confused with other things like autism that's developing. Also, there's something, as people know, used to be called prodromal, which is that early stage when it's not quite psychosis, but it has psychosis-like qualities. And that's now called high risk, clinical high risk. And some of the younger people that we see actually are at clinical high risk, but they're not fully in psychosis. So we took 15 to 40 as the age.
Thank you.
Yeah, and we had people who, I remember there was a woman who she was a bus driver and she had 2 kids and she was in her 30s and had her first episode. And I was so glad there was a program available for her.
Yeah.
Okay, well, let me put up this. I'm not quite sure how I'll do this. Let's see.
So if you just exit, yeah, just like that, and then bring up the YouTube.
Okay, now I'm going to put up this video. It's on YouTube. It's from a company called, I don't know why my cursor's not cooperating with me here. There it goes. Okay, there it is. It's from a group called Mind Map out of Connecticut. And there is a first episode program, not Navigate, but it's called the STEP program. And what I love about this first episode movement here in the United States is we all share resources. Whatever it is that one group has, they try to make it publicly available so we can all use it. And this is about a 6-minute video, and it talks a little bit about the experience of it having a first episode, but it's from the point of view of the young person. So I'd love you to have a chance to see this, and then we'll talk a little bit about it afterwards, because I think one of the things that really helps us be good New Journeys programs is being able to put ourselves in the shoes of the person experiencing this, to be able to put ourselves in the shoes of the family whose loved one's experiencing this. Is that really, I think it helps us be even more effective at what we're doing. So I'm going to start it and then make it, and I'm going to make it big first, victory, and then I'll start it, And if someone can just let me know if something's not working about this, we'll just shut it off, because there's no point in seeing something garbled, but I'm hoping it will work. So here we go.
It's working.
Oh, good. Thank you, Brian. I'll put.
Maybe if you bring up the volume just a little bit.
I noticed that performance had decreased significantly, and I was constantly tired, and I didn't want to be around anyone. I lost my appetite. I couldn't focus. All I thought was negative thoughts.
It was very scary. A lot of people joke that it was like
It appears it froze.
program. I kept myself hidden.
What froze?
It appears the video froze.
Oh, no.
Yeah.
Is the voice still coming?
We can still hear the voice, yeah.
Really started isolating
You
from.
can hear, yeah, it sounds like it's moving forward, but just the image is frozen.
Okay, I'm stopping it. Okay, so the image froze. Brian, do you have any ideas about how this might work?
Maybe exit full screen,
Exit full screen.
and then let's try it again. Could just be it's kind of bandwidth overload.
Bandwidth thing. All right.
It's still on the full screen though.
Now it's a dinky screen. Okay, let's see.
Keep playing for her.
Yeah.
Is it our connection?
Very weird.
Because it doesn't freeze here.
Do you see what I'm gonna share my screen, and then I'm gonna have you share your screen again, okay? Or actually, why don't you just stop sharing? There should be an option at the top, and then reshare your screen. Just kind of reset it.
Stop share.
Yep. And then share your screen again.
I'll try it again.
Yeah, and we'll just.
Tired, and I didn't want to be around anyone. I lost my appetite. I couldn't focus. All I thought was negative thoughts.
It was very scary. A lot of people joke that it was like I was in the witness protection program. I kept myself hidden. I didn't want to talk to anyone.
You just sit there helpless, wanting to make a change, but realizing it's so difficult to. You may not have the power to.
I really started isolating from really everybody, all of my friends at school, my community, my family, my siblings, just everybody that I used to be even acquaintances with.
I decided to kind of isolate and not really talk to anybody about it, and it got me to a darker place.
I really was in denial at first. I said, oh no, this is not happening to me. It wouldn't happen to me. Of all people, it's gonna happen to anybody else. Just not me. I really was unsure about everything. I didn't know if these feelings that I were having were valid, or if my thoughts were valid. Because I couldn't even believe what was going on inside of my own head. It's like you have a hard time trusting yourself. Like, am I making this up?
And based on how society thinks of people with mental illness, I was really in denial about getting treatment, and I just didn't think I could handle what I was going through.
As unbalanced, as out of control as I felt like I was listening to all these people who, and I come from a very white picket fence town where a lot of these issues are not discussed at all. And to hear all these people who I just look at and think they live such perfect, idealistic lives tell me about the problems that they've gone through with depression, with anxiety, with all these mental illnesses. And for me to think that I was alone this entire time just felt silly.
I almost felt embarrassed to say anything because mental health was kind of like a forbidden subject to talk about. But with mental health, a lot of the symptoms, don't necessarily show physical evidence of that you have it.
I just didn't see the light at the end of the tunnel, and I had no hope. And I didn't want to go to school because I didn't think there was a point because my academics were decreasing. I was a straight A student and they went to straight D's. And I didn't think I was going to graduate, which meant that I wouldn't go to college, which meant that I wouldn't have a career. So I didn't see a point. There was no point to life except for laying in the bed or dying.
When I finally opened up, it took a while, but the people who really meant the most to me were so supportive and so comforting, and it made me think, wow, I wish I really did let them in earlier.
Therapists and medication are kind of like a pair of jeans. You have to try them all on before you find the one that really fits really well.
I really took it upon myself to go seek help. I went to therapists. I had a therapist at home. Then eventually, when I re-enlisted back into school, I got a therapist at school.
Yeah, I think you should become more educated on on the diagnosis that your child or friend might have, because it's hard to understand how someone's going through something if you don't know what symptoms there are, or even if you notice that they're going through some things, it's better to understand why they go through these things instead of punishing them.
I just started to come to a point where I said, look, I want to take an active role in my recovery and my mental health. I started to say, I don't really want to be, feeling prisoner.
I feel like light years away better from where I was just a little over a year ago when everything came to a head.
Don't be afraid. You're not the only one. There's so many of us out there, and a lot of people don't talk about it, and they let it go unnoticed.
You have to kind of engage them in what's going on in the world, and not just in their bed and in their bedroom and in their thoughts and in their head. And you want to make sure that they're feeling loved. And although they won't come out and say, like, I need your help, because they put up this front that they can do it on their own and they want to do it on their own, they actually need you, and that's really important.
You kind of get more educated on what to expect with their illness, so you should do the same with mental illness.
Exciting is a bad word, but I'll use it. Exciting to know that, like, it is just a normal struggle that people do go through, and that I'm not, like, part of some crazy freak show that I had set up in my head.
To those who are struggling right now, I would advise you to remember that you have a heartbeat because you have a purpose.
I just one day found that direction, and found that ability to, guide myself to a direction, that was pointing north or pointing towards recovery. I just found that, the cognitive behavioral therapy really started helping me.
Keep hold of my little mantra, still I rise.
You can help someone through your story of success who needs you. Someone needs you. So keep on holding on and being strong. And it's okay to break down just as long as you get back up. Okay, let's just stop a minute. Any reactions to that video? What did you think?
Are we on?
You may have to unmute yourself.
What I like about it is this normalizing, and just showing a range. I think it's the only video I've really seen where a number of people are portrayed versus just one or even
Right.
two.
That's why I chose this one, yes.
Yeah, I like that about it.
Because there were clearly individuals. And each had experienced it slightly differently and had a different way of talking about it, and that's the way it's going to be. It's one way. Absolutely. Any other thoughts that I'm seeing that did any of the clients stand out to you? Their story. I was struck by the young lady who described she was straight A's and became straight D's. That she thought she had this logic that if she wasn't going to she wasn't going to finish high school, she wouldn't go to college, and then she wouldn't have a career. So it was no point in doing anything right now. It was like this kind of cycle, this link of beliefs that she had that was really keeping her stuck in bed. And what an intelligent, lively girl she seems to be now. So that was just, I thought that she stood out in some ways. Have any of you encountered young people that have first episode psychosis that this makes you think of? I see a nod from Sarah. Oh, and some other people came on, yay.
Yeah, I was actually thinking about a client that I'm working with right now that engagement has always been a little bit tricky. She's in, she's out. And one of the things that I think is really challenging for her is accepting help. Because she really sees herself as the person who has needed to be strong for her family. And this difficulty that she has with asking for help or being in a help-seeking role has been really challenging in a lot of ways, including just coming in for treatment. And I liked at the end of this video, this kind of reframe around how much they have to offer other people. And it's okay to have these setbacks. It's just, you just got to get up every time and put yourself out there and be able to help others.
Yeah, and that's, you put out something there that I think it's you said it's hard to engage sometimes, this young lady. And you can see from how these young people were talking, how that would make sense that it's hard to engage folks, because they often are in denial about their symptoms in the sense that they don't understand them and wish they weren't there and prefer to think they don't have them. It's understandable. And with the negative symptoms, keeping them from feeling like things are worthwhile. It's really, it's very challenging. And I thought that young lady did a nice job when she said, help us get interested in the world outside of our bed. Any other thoughts before we move on? So let me put this on the big slide. There, all right. So that brings us to that, about the fact these are such young people, and just like the ones that we saw. And unlike if you've worked with multi-episode patients, that these folks are younger, obviously, and many may still be living with their parents. So if you've been working with multi-episode clients, sometimes it's hard to find the family, hard to locate they've burned so many bridges. But with this younger group, they're often still even living with their parents. So that's important to keep in mind, that they're available, these families. It's not necessarily easy to get them involved, but at least we usually know where to find them. Their peer relationships and opinions, what others think of them is very important. I think a couple of those clients in the video were saying they were embarrassed or they didn't want to be seen. And I think that's something that's something that we need to keep in mind, is that for this age, one of the most important things is having friends and people to do things with. And that's something they might engage with more than they will with the idea of getting help for their symptoms. It's like, I just want to have friends. So peer relationships and opinions are very important. They're at that stage where they're going to school or having their first job. It's a very exciting time, but a very nervous-making time. And they're also in the process of separating from their families, in the process of developing romantic relationships. And they're concerned are these experiences that they're having going to keep them from having a boyfriend or a girlfriend or a partner? They're extra sensitive to being told what to do. Not that none of us want to be told what to do. It's not that. It's just that at that age, sometimes they want to feel like they can do it themselves. And I think that's something Sarah just mentioned, that her client feels she should be strong for others. But I think one of the clients in the video was saying, I wanted to do it myself. I didn't want to go out and get help. I wanted to do it myself. I got this. That's something we sometimes hear from I got this. We don't need this. I don't need your help. So there's a high rate of substance use, so that's complicating the picture. And they often feel kind of invincible. What I'm experiencing, it can't be anything serious. It's just, it's going to go away. It won't happen again, so there's no point in worrying about it. I think one of the young ladies in the video was saying, this can't be happening to me. It could be happening to other people, but it can't happen to me. And I think there is something about that younger age where they just don't think that anything bad can happen. And then the other thing involved, as we mentioned before, is the trauma of experiencing psychosis. It's not only traumatic because of the symptoms, but sometimes it's when we try to get them help and they are involuntarily committed. That can also be traumatic. So it's the actual symptoms are frightening and traumatic, and sometimes the getting treatment can be traumatic. So if you're working with someone who's just been in the hospital for the first time, it can be quite a shock for them. And that we know that post-traumatic stress disorder reactions are a common response to psychotic symptoms and treatment. So part of one of our interventions, individual resiliency training, or IRT, is really designed to help with preventing it from becoming something they can't talk about. Okay, so let's think about, we've talked about the population, where to find them, what the treatment's based on. Let's talk about the team for a minute. And as you know, their manuals are online, and you'll also get them at training. But on page 24 in the team members guide, you'll see a nice kind of summary of what the different roles are on the treatment team. And just to go over them briefly, is the director and the family clinician role are usually combined. Then there's a prescriber, and we say prescriber rather than psychiatrist only because sometimes it's nurse practitioners or physician's assistants. There's an individual resiliency trainer. There's a supported employment and education specialist. There's a case manager usually. And there's, thank goodness, we've had a lot of teams that have peer specialists now. We're very pleased about that. And each team member is responsible for a different intervention. So the prescriber does the medication management, the director family clinician delivers the family program, etc. And what some people have told us is they like that approach because they learn their role quite well, and then they depend on the other people on the team to have learned their role well as well, that they don't have to master the whole kit and caboodle, but you have your part and you coordinate immensely with your colleagues. So let's look at each of these. The individualized medication management, there's kind of a mantra to that, which is start low, go slow, and pay close attention to side effects. And by starting low, we mean that young people need less medication to be effective. What's a standard dose for multi-episode client? Maybe half for a first episode. Also, you don't want to go up increase the medication dosage because it takes the clients a while even though they're more effective, it takes them longer to kick in. So you want to start low, go slow, and then be very conscious about side effects because young people are more susceptible to side effects than even our older population. That's why we have the second item, which is using a questionnaire. to monitor whether the clients are taking their medication, what their symptoms are, and what side effects they're having. And we use that questionnaire at every medication visit. And because we want to nip it in the bud, if there's side effects there, we want to really address those quickly, because we all know that when people have side effects and of course they don't like them, they're more likely to stop taking the medication, and we don't want that. The third thing is assessing physical factors, because sadly, some of the side effects of the medication are things like weight gain, change in lipid levels, and glucose levels, is that we really want to make sure that those things get nipped in the bud too, because a lot of you who work with older clients, the diabetes is very common, and weight problems are really tough to deal with if you've been heavy for a long time. But if you catch it quick, it's much easier to keep the weight at a good weight for that person. And above all, we want the prescribers to use shared decision making. This is not one of those approaches where the doctor says, you take this medication because I say so. Nobody likes that. And especially a young person is going to say, oh yeah, right, I'm not going to do what you say. So it's like really getting them involved and learning about the medication and what the medication can do to help, getting their point of view about, are the symptoms better? Are they not so good? Is this, and learning about the side effects. It's involving the client directly in the medication management. The other intervention, which the family clinician does, is called the family education program. And when we say family, we mean the client too. Is that the client doesn't have to come if they don't want to, or if they're uncomfortable coming, but we like it if they can. We encourage the client to come, because we want to shore up the family relationships in terms of under the goals of the program. The family's going to be there long after we're gone. And we want the family to kind of know the information that they can use to help the client. And we want also, one of the things that's cool about having the client and the family in the same room is you can help them be able to talk to each other openly about the illness and about the symptoms, that it's not a no-fly zone, that it's not something that they have to avoid talking about. It can be like talking about about a headache. They wouldn't be ashamed to talk about a headache. So there are 8 family sessions in the family program. Most of them will take more, these are family education topics really. And they might take as few as 8 sessions, but sometimes they take longer because there's quite a bit of information for the family to learn. And sometimes there's a lot of other things they're concerned about as well. So as you can see from this slide, that it's a range of topics, but ranging from facts about psychosis and medication, all the way down to effective communication. And it's important that families get equipped with this information, because they're with the client so much more during the week than we are. And if a client starts to have some difficulties, they're the ones to see it first. So we really want them to be our front line. Okay. Supported employment and education, or C, is to help people develop and achieve their goals. That we want to have them think about what it is they want to happen in their life and what it is that we can do to help them get there. And C services are very similar to IPS, which stands for Individual Placement and Support, which has been around for a long time, which is a great approach. And I think that's going to be the primary way that Washington is going to proceed, is with the IPS approach, kind of seasoned with some SEE, with the what we offer tends to be with supported employment education is the education piece and the young person piece. So it's what you're going to be getting in Washington will be like IPS plus young person plus education. And it's very important that people not have to wait. If they're interested in school or work, we want to jump on it. We don't want to say, oh, you can't, it's too soon, it won't work, it's too much. It's like, well, let's try to work with you where you're at. And let's break it down into really small pieces. We don't want to overwhelm people, but we don't want there to be long waiting periods, because if we put folks off, they sometimes lose their interest. So we want to get them working and in school as quickly as we can. And I think one of the important parts about IPS and SEE is that the vast majority of services take place outside the office. So the C specialist is often out there in the community, talking to prospective employers, visiting colleges' campuses, taking someone to visit a college campus, scouting out where the person could get clothes for an interview. It's a very active outside the office kind of role. Yeah, sorry. Individual resiliency training. And we were going to call it recovery training. And then we realized in talking with young people, they don't resonate with the word recovery because they don't think they have anything to recover from. They keep thinking this is a one-off thing. Recovery is for drug addicts, or recovery is for somebody who's been sick a long time. But they do resonate with the idea of resiliency, of bouncing back, of going with, being able to continue with their whatever they want to be doing in spite of challenges and adversity. So we decided to call it individual resiliency training, and that's been pretty well received by the clients. It's weekly or twice a month, and there's what we call standard sessions, or standard modules, and then individualized modules. So we think all the standard modules are important to get, and these are the standard modules. Sort of an orientation, a goal setting, learning about psychosis, learning about preventing relapses, processing the psychotic episode, and focusing on resiliency. So those are kind of like the standard modules. And then building a bridge to your goals is like, what other modules might be helpful to you? What other things are you working on that, that might benefit from having more information and skills? And that's where we come to the individualized modules. And dealing with negative feelings has a lot to do with cognitive restructuring. For those of you who are familiar with CBT for psychosis, that's one of the primary tools, and it has to do with being able to think of other reasons something might be happening rather than just the delusion or hallucination, being able to examine some of the feelings that people have around the symptoms and being able to look at them in a different way. There's a module on coping with symptoms, which is coping strategies like how, using distraction when you're hearing voices, trying to get involved in something else, or maybe wearing earbuds when you're trying to, when voices are interfering. There's a module on substance use, and I have to say, I think we should move that to the standard module because it's just much more common than it is rare. Having fun and developing relationships is a module that a lot of the clients really want to work on. Anything that has the word fun in it is going to be attractive to all of us. Then making choices about smoking, that even though smoking is on the downslide in the US, is that a lot of our young people have come to us smoking already, and they're at a high risk of developing smoking habits. So that we really want to put it out there as making choices about smoking. Healthy lifestyles is a module on that, and that ought to be moved, we also think, up to a standard, because if you address the weight issues with exercise and diet immediately, it's much more likely that someone will be able to maintain their regular weight. It's much easier to maintain than to lose weight. So I think we ought to, in the next go around, move that one forward. And then there's several other individualized resiliency exercises and things that people might help them be even stronger, the internal resiliency. So IRT is a very big manual if you've had a chance to see it. In fact, it usually comes in 2 big binders, but it's very well organized. So it's broken down into those chunks, and you don't have to do it all at once. And we've gotten a lot of interest from even beyond that. I see some people laughing. It's big, isn't it? But I'm amazed at how many times there's something in IRT that applies to a particular client. When I'm on call, I do calls for family and directors, and oftentimes the directors are really glad to hear, we got a module for that. We got a module for substance use. We've got a module for coping strategies. So it can be quite the backbone for the treatment that goes on. Case management. When we first began, I would say we were quite naive, at least I was. I thought, these folks are early in their illness. They're not going to have so many case management needs. And that's incorrect. A lot of them do. We even have some young people who are homeless. So there's housing issues, medical care, transportation. Some of our young people are parents, and they need some things like parenting classes. So there's lots of things that case management is just critical for. So we think that's an important role on the team. And most of the teams that are coming up these days are having a separate case manager that is a critical part of the team. And then peer specialist services. Again, we didn't have those in the initial RAISE program, but we're so happy we have so many of our teams now have peer specialists. And they can assist in so many ways, like sharing their experiences, making the client not feel so alone, providing examples of other, things that they've been able to do, or going out with folks to kind of just to go to the mall and say, hey, you can still do the things you used to do. Or they might help with achieving goals, like helping set up if someone's going back to school and they're disorganized about their homework, they might be able to just go and, hey, let's look at your apartment or your room and see where we can set up a homework area for you. So they can be very hands-on, and they've been very helpful. But to be honest, none of these interventions would be nearly effective if you didn't have the whole team approach. So what you want is to have a chance to meet together, even as soon as possible, that the clients know that you're a team and that the families know that you're a team, and they get to meet everybody. So if you can introduce folks at the beginning of treatment, that's really helpful. And then as a team, it's like your goal is to have each client get the benefits of each intervention. So you may be an IRT specialist, but you really want the client's family to be able to get some help too. So any in you have in IRT that you can boost to maybe make the client more willing to able to see some of the advantages of having their family involved and maybe getting their permission to get the family involved, that would be terrific. Or maybe you're a family clinician and the person, the family says, Joey says that he wants to get a job now. Ooh, now that's your in to talk about supported employment. And so it's like you're always thinking of how the client can get the best from the whole team. I would say that another thing about the teamwork is that whoever has the most rapport with the client, you kind of want to use that and spread it. So having joint sessions, sometimes maybe you're the supported employment person and the client really likes to come to you, but he's a little nervous about the IRT. Let's see if we can have a joint session. The IRT can come in, you can meet her, she's really a nice person, and then she can tell you a little bit more about what she does. But you're using the rapport you have as supported employment to kind of spread that to the IRT. I would say that everyone on the team is speaking the same language, that they're all talking about hope and recovery, they're talking about resiliency, they're not talking doom and gloom. And that everyone on the team uses shared decision making. And we mentioned that a little bit with the prescriber, whereas the prescriber will work with the client and make sure they're educated about the different medications, and that their input is also very valuable. You want to do the same if you're a family clinician or an IRT or a supported employment or peer. None of us are going to boss these clients around. It's like we're trying to think about informing people, helping them make educated decisions, but really equipping them to have a dialogue rather than to be authoritarian with them. Okay, so here's a little bit about when you think, so we've got the different pieces of Navigate. How does it look in terms of almost like stages? Is that the first stage is recruiting and responding to referrals. And I'm going to say this has been far more important than we ever thought, is you got to do, what do you call it, hunt and gather. Hunting and gathering is go out and really, really make people aware of what you're doing. And be able to give presentations around the city, around the town, at the universities, at the schools, and get folks to come in to be evaluated about whether they would be a good match. And then the next step is, if people do come in and they do meet criteria, is to engage the client and family. And that is by engaging, try to connect with them. Show that you're interested in find out what they're interested in, find out what their experience has been and what do they like from treatment. And then if they're agreeing to be involved, you want to orient them to the whole program and to your specific intervention later. But it's part of shared decision-making is we want people to participate in the program, but we want them to know what the program is so that they kind of know what they're getting into and what they might get out of it. And you want the clients and families started into the interventions as soon as possible. And you're going to use some clinical judgment with that. You don't want to overwhelm the young person. But the more that they can start to get the benefits from each piece, the sooner the better. And you can stagger things and depending on what the client wants and the family's able to do. Then I would say coordinating your efforts. And that's what often happens is when you understand, depending on your role, it's so helpful if you know other people's roles. If you know what's also available through your whole team, is that I think that helps you to encourage the client and the family to be involved. Here's a flow chart that kind of talks about the first 6 months, and it's not rigid. It's just because we're always going to want to be flexible and respond to what the client and family needs and is able to do. And I'm just going to, there is an error in this slide on my part. It's nothing to do with what you've done, where it says compass notes. You will see these compass notes everywhere in that first column. That was for RAISE, and it's not something that we do anymore because we don't have access to what is called Compass, which was the computer-aided medication algorithm program we had. So I apologize that that's there and might be confusing, but everything else is correct. So it's like the first week is orientation by the director and the team members and being able to meet the team, and hopefully having that the prescriber be able to meet them in the first week. We don't want people sitting around for 3 more weeks still having symptoms. We want to get started with them meeting with the prescriber as soon as possible. And then you want to be thinking about getting people started in IRT. Sorry. IRT and family and SEE in that first month. And then to be thinking about, a lot of times what we suggest is at the end of that first month, there should be a collaborative treatment planning meeting, so that you're going to want to be meeting to figure out what it is that everyone's hearing from the client, because each of you in your roles will hear from the client during your first interview or two. So in IRT, what does the client tell you about the goals they're interested in? In family, what does the family tell you about what used to be the client's strengths and what they used to enjoy doing that they'd like to get back to. From supported employment, you might know specific things about school and work that nobody else might not have heard, but you want to put that all together for the treatment planning meeting. And you want to, I would say, pencil in a treatment plan based on what the client has told you all, and then to have the client have that available to the client and family when they come in to bounce off of. It's based on what the client's already told you. You don't have to reinvent the wheel, but it's like putting it all together. Anything on this chart that looks a little bit dubious to you? Someone unmuted themselves and sounded like they had a question. No? Okay, so we'll go to the next slide then. There's a lot, I think, of similarity between a Navigate team meeting and, say, a PAC team meeting. Is that it's very essential everybody gets together and becomes aware of what each other is working on, and to kind of make it a joint effort. Without those weekly team meetings, it would be very hard to know what's going on. There's also supervision meetings. The director is asked to supervise IRT and SEE. There are also either meetings or consultation calls with the consultants. And you're very fortunate to be having in-state consultants for IRT and family, and also for SEE. There'll be in-person support. I mean, I keep saying in-person, I mean in-state. I apologize. And then there'll be collaborative treatment planning meetings. So those are the nature of the meetings that are part of Navigate. And what I'm just going to say is that their goals to those weekly team meetings, they move pretty quickly. But what we want is to have we want to start with something positive that's happened. Each Navigate meeting starts with, what's something good that's happening for one of our clients or families? And that could be anything from, well, so-and-so finally downloaded an application for the GED program, and they didn't want to do that before. That's cause for celebration. Or it might be something like so-and-so is getting married. You know, it could be any number of things, but you want to start off with that positive news to kind of keep in mind, because this work can be stressful. And it can be slow at times. So knowing that there's good things happening as well as problems is important. And then you want to update on all the clients and hear where they're at with each of the interventions, and then plan next steps. And I think this is just a team meeting agenda that we'll probably go over in more detail in the in-person training coming up, just to talk more about how to run a team meeting. And here's an example of a client tracking sheet that you might use. I'm just going to go back to that, sorry. As you can see here, the client in the left side is the client's initials. What their goals are is always the first thing you want to talk about when you're talking about the client, because the goal of the client is the most important thing to keep our eye on. They want to hear about what does IRT say, what does family say, what does SEE say, what does prescriber, case manager, and peer specialist, what do they say? And just real briefly. Okay, so then the weekly supervision meetings are done in-house by the director, and they're for IRT and SEE. And I'm not going to go into the IRT supervision agenda because I think that's more appropriate to do during the director training, as is this SEE supervision. Okay. I'm just going to say prescriber consultation. These are monthly calls with the prescriber consultant. I just want to put in a plug here, is that a lot of our directors of teams have found it useful to join the prescriber calls, because they can hear, they can learn about prescribing practices and it's a lot of the directors have found it really helpful. It's very educational, and it helps us who are not trained in medicine to really understand more of the nitty gritty of this, of what's involved in medication. So just want to say that for those calls. And in the past, Dr. Robinson has welcomed folks, and I'm sure that your prescriber will also welcome folks on those calls. There's some suggestions for person-centered treatment planning in the team members guide. And I think that what we've been hearing is one of the important things is to kind of pull together what you know before the meeting, because the client and the family, they're brand new to this. They've never been to a treatment planning meeting for the most part. So having it so that they feel confident and that you've kind of saved them some work by having worked with them individually and put your thoughts to put down what they thought. Okay, just going to skip these on the treatment plans, and just I think what I'd like to do is kind of wrap up a little bit early, and then we can have some times for question or comments. I would say congratulations. You're doing a great job in Washington of implementing Navigate and spreading it. That's terrific. And you really are part of what's going to change the trajectory of schizophrenia in this country. It's like every team is really making difference in people's lives, and what families can grow to expect, and what the general public will start to learn about schizophrenia will be quite different. And as national trainers, we look forward to working with you all and with your state trainers, and anything that we can do that can be helpful, we're more than happy to do it. And so I wanted to thank you for all that you are doing. It's really a service to the community. And I wanted to pause and say, what if there's anything about what we talked about in the webinar that you might like to either hear more about. I can't tell you less about it because I can't take it back, but I'd be glad to say more about something, or something that might have been confusing, or something that you might even disagree with. I'd be happy to hear about that.
I was just curious about the average duration of treatment within the Navigate framework.
During the research, I think it was 21 months. Does that sound right? Yeah, something like 21 months. That was the average duration of untreated psychosis. Between 18 months.
Sorry, not the untreated, but like the actual rolling out of the IRT and the treatment modality that they were engaging with clinicians.
Oh, okay. Like uptake of the treatment?
Yeah.
Well, there's going to be a paper coming out about that. And so I don't want to speak about something that will be better addressed there, but I will say that we did track that. And we found that I think the most uptake was on IRT, because a person always has themselves. There's an individual to work with. But families sometimes there was less participation in the family model, in the family intervention, partly because some people, in spite of it being early in the illness, there was still a lot of strains in the family where either the client or the family wouldn't come in. So the IRT was the highest. SEE was popular too, because the goals that people have are often around working school. But I do want to say one thing about the prescriber is that after people stopped going to IRT and family because they'd gone through all the materials, or they'd gotten what they wanted out of IRT and SEE, the prescriber was the steady thing, the steady person they continued to visit. So the prescriber's relationship with the client is very important, because they're kind of the last person to have eyes on people on a regular basis. So I will just mention that. But was that what you meant, was like the uptake?
Yeah, partially that, and just overall how long treatment lasts. Like how long do you really end up working with someone? I don't anticipate that necessarily there's end at this time, but what you can kind of expect when you're embarking.
Navigate, it was 2 years.
Okay.
2 years.
And
Do you find that to be true now, Susan, just working with a number of states? Are you finding that people are working with them longer or a shorter period of time than 2 years?
I think it's a little early to say because a lot of the programs haven't been in operation for 2 years. We're having, but that's an excellent question, and I hope you'll be keeping track of that in Washington State. Is that would be very helpful to know what is the average length of treatment in Navigate. That would be very interesting.
Okay.
Love to hear another question. That was a great one.
Well, I think the tricky thing too with that is just with such a limited resource, how policy may dictate that too. Like it's, in a number of states, including our own, the 2-year window is generally referred to as sort of, the time frame for treatment. I don't think it's a hard and fast rule, but that's sort of generally what they're looking at. And I have heard, and just looking at some of those, like the OPUS data out of Scandinavia, it's interesting to kind of look at their long-term outcomes, sort of speak to this idea that maybe people need to be in some people need to be in these programs for longer, which I think may be a really important piece to bring back to the policy level. What are we really saying how long are we really saying people, could potentially be served in these programs? Or what does step down look like? Or what does transition to,
Less intensive, yeah.
Yeah, I mean, our hope is that a lot of people could kind of move forward and not need services, but also recognizing there's going to be some heterogeneity there.
Right, absolutely. And that's why we don't have with Navigate, we don't have a strict thing like you must be done in 2 years. We never say that. It's like it's a good thing to shoot for, like to try to have contact for at least 2 years, and it might be declining intensity. But if someone needs longer, if their symptoms aren't under control or they're up and down and in and out, I would say keep them longer. And I think what Maria is referring to with the OPUS, what's called the OPUS study, I forget what the initials stand for, but is that some clients, when they stopped being involved in the first episode program, declined. And that's something we don't want to have happen. So some of us are trying to think about what are good, like follow-up support groups, or something where there's a monthly check-in, or something where there's still some contact and availability, but not at the same level of intensity. One of the challenges is the budgets for mental health are shrinking. So the kind of programs that we might send them to are not necessarily available to them. So we have to be thinking about, in some ways, equipping our clients to take with them what they learned in first episode and take it to their next provider. And we have some suggestions about that, how to do a transition. So it's a little early for that. Anybody else have a question or concern? Okay. Well, I am so glad that we had a chance to be able to, even limited, to see each other a little bit before the training later this month. And I always welcome email, any questions or things that come up afterwards. Feel free to shoot me an email.
Sounds good.
Terrific, and we'll be making this recording available today. So just look out for an email from me to the whole group with a link to that. So
Great.
Thank you, Susan.
Thank you, Susan. Have a good evening.
You too. Have a good afternoon.